Okay, skin tears. We're going to whiz through skin tears quite quickly because I've been talking far too much and we should have actually done this before morning tea. So just looking at this picture, I think this is a really, really good picture. It just shows the difference in our skin as we age. So we've got that beautiful child's hand with that lovely soft skin, and then the older skin of a much older person, and the changes that you can see there. So basically, a skin tear is a wound that's caused by shear, friction, or blunt force, resulting in a separation of the skin layers. And you've all seen these. We've all seen them multiple times, I'm sure. People that are most at risk of skin tears are the extremes of age, so young babies and older adults. The people that are most at risk of skin tears are those people that are completely dependent on somebody else for all their activities of daily living. We all know what normal skin looks like, and we know that there's 3 layers. We've got the epidermis, the dermis, and the subcutaneous or hypodermis. And again, we've got aging skin, and these are the changes that happen as our skin ages. It gets thinner, the vascular bed becomes more fragile, the collagen changes, and we've got less subcutaneous fat. The skin also gets drier. And then we have the 4th layer of skin, the acid mantle. And this is often forgotten. People completely forget about this or never knew about it in the first place. So it's a thin, light, slightly acidic film that sits on the surface of the skin that is secreted by the sebaceous glands. It helps to stop bacteria getting into our skin, and it helps healthy bacteria to grow on the surface of the skin. And because of the acid mantle, the skin's pH is round about 4.5 to 6. Lots of different things change the pH of the skin, and we don't help it either. So if you look at the pH values of some of the most common things that are used on our skin, it's quite surprising. So if we look at in that pH 10 to 11, look at these things that are extremely alkaline, really, really bad for the skin. The things that either we or especially a lot of our older population really like to use. They love the Cousins Imperial Leather because it's got the little paper thing on it and it stops the skin the soap getting wet and soggy. They love that. Simple soap. Pears transparent. How many old ladies love Pears soap? Baby soap. Again, people think these are all really good for the skin, and they're some of the worst products that we can use. Neutrogena is pretty neutral. Pine tarsal, which is a product that I think gets forgotten about a lot, and it's used for itchy skin quite often. But if you think about it, it's not actually a magic remedy, it's just the perfect pH for our skin. So because it's a perfect pH, it's going to stop the itchiness and the skin problems. And again, there's QV wash, QV bar, are good, and the Cevitar are all good products that we should be using on our skin. So generally, this is just an example of some products. It's not something that I specifically endorse. It was taken from a high school certificate program that they did some research on. But anything generally that says pH balance is a good product to use. We know how skin tears occur. The wheelchairs, the wheelie walkers, slipping, putting on compression stockings. I often see this with people trying to put their own stockings on, or sometimes from carers that haven't been trained properly to put the stockings on, and they pull the stocking up the shin bone and take the skin with it. So you're causing more problems than you're fixing. So just looking back to our title, which is what's new in wound management, we have different skin tear classification tools. There's a Payne Martin was the first one in the early 90s, and then our own Carolyn Carville developed the STAR tool, and the most recent one is the International Skin Tear Advisory Panel one, or that's called the ISTAP, which is from 2013, which I personally think is a much easier one to use. The STAR one has 5 different categories. This one has only got the 3 categories. So we've got no skin loss at all, we've got a partial flap loss, or we've got total flap loss. Much, much easier to remember. This is just the algorithm from the International Skin Tear Advisory Panel. And again, you can download this free of charge. It's a very big document. This is just part of it. And this is from QUT. This just talks about how we should manage our skin tears that we see. Obviously, the most important thing is to control the bleeding initially and clean under the flap. You often find that you've got blood clots underneath that flap. The wound can't heal whilst the blood clot is still there. So we do need to get rid of that blood clot, realign the skin, and either a cotton wool bud dipped in saline or sterile water, or one of the wound swabs. That works just as well, and it's got a longer stick on it generally. Will help to unroll the wound flap so you can lay it back over the wound again. Apply a low adherent dressing. There's lots of them around, and I'm really pleased to see that lots of people have been looking at the different products around, which is great. Make sure that your dressing extends over the wound surface and onto the surrounding skin by at least a couple of centimetres to give it good adherence. You can leave that in place for 5 to 7 days, but please check it the following day just to make sure. It might be bleeding the next day, it might be leaking out of that dressing the next day, but if there's no problems at all, it can be left for a week. And there are some dressings that can be left for 2 weeks these days. This just talks about most suitable dressings for skin tears. I will send a copy of this with the other information that you're going to get. Skin tear prevention, it's pretty self-explanatory really. Protection, make sure that the patient has a safe environment. The protection bandages, tubular bandages that you can get that are nice and squodgy and protective are great tools. Shin pads, anything that the patient will wear to protect the skin. And one of the most important things, of course, is maintaining that acid mantle, keeping the skin in really good condition. And, you know, you can talk to your patients about what they do and don't use. And also talk to their carers. That's, we're about back on time now. Okay, so we'll now talk about wound dressings. And I'd like to make it as simple as possible because people get very, very hooked up on dressings. And there's, as you've seen, there's millions of different dressings, wound care dressings, that you can use. And if we keep it basic, I just think it's a bit more simple. So basically, if you've got a dry wound, add some moisture to it. If you've got a wet wound, soak that moisture up. If there's a hole, fill it. And if it's infected, treat it. And it really boils down to simplicity like that. Don't get hooked up on different brand names. So what we're trying to do with our wounds is debride any slough or any necrotic tissue from the wound surface. And we do that by using dressings for autolytic debridement, which means that the macrophages are liquefying and eating that slough off the wound bed and cleaning the wound up for us. So the wound on the left is before we start. The wound on the right has had an appropriate dressing on there, which has caused autolytic debridement. So the dressing isn't actually healing the wound. The dressing is providing the correct environment for the body to heal the wound. So we need to provide a nice, moist, not too dry, not too wet environment for them macrophages to work and clean up the wound, and then the body will go about healing the wound itself. So looking at dry wounds, these are all pretty simple wounds, but they're all very dry. And for the epithelium to slide over these wounds, they need to be moist. This is like the epithelial cells need a nice moist environment to be able to slide over each other. If the cells, if the surface is very dry, it's like rubbing sandpaper on sandpaper. It's not going to move very easily. You'll also find, if you've got a dry wound, that the healing is slower and that there is far more scar tissue. You also could find on a deeper wound that's got a scab on it that the wound is getting worse underneath that scab, and you don't know about that until you remove the scab. So we can remove the scab either by sharp debridement, or we can remove the scab by applying a dressing that will provide a moist wound environment. And there are different dressings. There's no one right answer to any wound. There's lots of different answers, lots of different dressings that will do the same job. So we look at our wound, and rather than say, what dressing shall I put on that? We look at the wound and say, what do I want to do to this wound? What do I want to achieve here? Okay, I need to add moisture. And then look at your dressings. Which of these dressings will add moisture to this wound? So these are just a couple of dressings that you could use on them wounds. Hydrocolloids do a multitude of jobs. They will absorb moisture and they will also add moisture. So they're a very, very old dressing, but they're still effective and they're still used and still very appropriate. And hydrogels. Hydrogel comes in a sheet, or it also comes in a tube of some description. So you can apply that. The sheets are really good for superficial wounds, and the gel, the amorphous as it's called, is better for a cavity because the gel will sit in the cavity. It's harder to keep the gel onto a flat wound. Wet wounds. I bet you've seen a few like this. So we can see that there's a lot of moisture in these wounds, and we need to absorb that moisture. That wound, actually, yeah, certainly the left and the central wound haven't had an appropriate dressing on. The surrounding skin is a little bit macerated. So looking at that, it may well have been an appropriate dressing when it was put on, but it's not an appropriate dressing today. So we need to look at what we need to do with this wound and get the right dressing onto it. Certainly that left one, if we don't change our treatment plan, that left one is going to turn into cellulitis in no time. So products for wet wounds, probably quite a few more. Again, hydrocolloids, providing the wound isn't too wet and that the hydrocolloid can absorb that moisture that there is there. Foam dressings are a little bit more absorbent. Hydro fibres go on dry and come off wet. So you can see that hydro fibre there. It turns into a gel, it goes on dry, it then absorbs the moisture, and when you take it off, it has turned into a gel sheet. So it comes off in one piece. We've then got super absorbent dressings, which generally work through absorption and evaporation. So if you put one of the super absorbent dressings on and then cover it with a film to make it waterproof, showerproof, you're probably stopping the dressing from working properly. So a lot of these super absorbent dressings, they work by absorbing the fluid into the dressing and then it evaporates into the air. And that's how it works. So if you cover the surface of that dressing with a film, it can only do half the job, and you'll find that it's nowhere near as effective as it should be. You may also find if you've got suddenly got a lot more exudate, that something is happening, maybe the wound is getting infected. And if it's getting infected and the exudate, then you maybe need to look at antimicrobial dressing for a short time. So we can often reduce the amount of wound infections by treating before it turns into a systemic infection. We'll talk about that a little bit further down the track. Got it. Hydrocolloid tip. Couple of things about hydrocolloids. They are great dressings. However, if patients aren't warned that they will see this bubble underneath it, they often get panicky. I've had people ring me and say, oh, I've got pus underneath the dressing. It's not actually pus, it's the dressing doing what it's meant to do. So the hydrocolloid will absorb exudate and then it turns into a bubble, which stops the dressing from sticking to the wound. It does look like pus if you don't know any better. So beware of that. A week or a leak, generally, if the wound fluid or that bubble is leaking like that and somebody's put tape over it, because you've now got an exit point for that fluid, you've also got an entry point for bacteria. So if the dressing is leaking, please change it sooner rather than later. It's less likely to get infected. And the other thing is these dressings are smelly. So don't worry that it's a wound infection. If you've got a patient with a hydrocolloid dressing on, remove the dressing, bin it, bag it, and get rid of the dressing and then reassess it. If the wound is no longer smelly, it was the hydrocolloid that's smelly and not the actual wound. It does have a very distinctive odour, and once you've smelt it, it's one of them things you usually remember. So cavity wounds, we're going to fill them. How do people get cavities in the first place? It could be the result of surgery, could be abscesses, a big abdominal surgical wound that's maybe dehisced and gone back for surgery, and they want it now to heal by secondary intention. So you've got a big cavity to fill. Or it might be a chronic wound. For example, a wound in a limb that's either caused by an ulcer or more often than not trauma, and that trauma has caused a cavity in a large limb. So the reason we need to fill the wound is so that the wound can heal from the base up towards the surface. Ribbon gauze. It's the bane of my life. Ribbon gauze, I know surgeons still love ribbon gauze. They still use ribbon gauze, and in hospitals they still quite often use ribbon gauze as a dressing 4 times a day. And it's, I don't know why they do it. I can't explain that, but they do. Generally in primary health, there's far better dressings that we can use, and my experience before, in the past, when surgeons have ordered this for patients being discharged, is to ring the surgeon and say, I'm sorry, we don't even stock ribbon gauze. We can't do that. Therefore, if you want it doing, you do it. But we are happy to use whatever dressings you have in stock. So offer them an alternative, and generally they will say, yep, that's fine. I don't really care. Just heal the wound for me. So long as you give them an alternative, and you can use a hydrofiber, you can use an alginate or whatever dressing you have that will fill that cavity and provide a nice moist wound environment, and also absorb the wound fluid. How many people still have surgeons asking for ribbon gauze? It's not just Hobart then. So cavity wounds, suggested dressings, foams. When I say foam, these foams are specifically cavity foam dressings, and it's like a little sachet that is filled with foam chips that goes in one piece and comes out in one piece. Hydra fibre is a great alternative to the gauze, the ribbon gauze, and if the wound is big enough, then negative pressure therapy. I don't know how the negative pressure therapy is funded in other states, but in Tasmania it's usually paid for by the hospital, and the person usually is discharged from hospital with negative pressure therapy and managed by the community nurses. Occasionally I see people in nursing homes and start negative pressure therapy. Generally these are on people either with private health insurance that will pay for it for them, or Department of Veterans Affairs that will also pay for it for them if there's a need. So when we're packing wounds, it's not a case of pack as much in there as we possibly can, because the dressings that you put in will expand. They'll absorb the fluid, then they will expand. And if the wound was full to capacity to start with, by the time that dressing has expanded, it's going to be too big for the wound, and it's going to either fall out, hopefully, or the worst case scenario, it will stay in the wound and it will put pressure on the wound bed. So the sides of your wound, it will put pressure on and it will cause more harm than good. So when you pack in, just pack very loosely. Make sure that the dressing that you're putting in is absorbent enough to protect the surrounding skin as well, and that it's not going to cause maceration. This is going back to the triangle of wound assessment, of course. Whatever dressing we put into there has to come out. And so if we're putting 2 pieces of something in a wound, we need to make sure that that is recorded so that the next person that comes along takes 2 pieces out. We don't want to leave anything in there that shouldn't be in there. So infected wounds or critically colonised wounds. What we need to do is restore the correct balance of bacteria in the wound. We want healthy bacteria living in there. We don't want all the bad things that are going to lead to infection. Lots of different products around. These are just a few of them. Silver is an excellent product. Iodine, Medihoney, Prontosan and Flaminol are all in use, depending on what you're trying to do with your wound. So we've got absorbent dressings, we've got dressings that will absorb and donate moisture. Just one word of warning about honey. Lots of, especially elderly people, they like the thought of having honey on the wounds because they know somebody that had Medihoney and it healed their wound, so therefore it will work for them. And it is an excellent product for a critically colonised wound. However, please make sure that whatever honey they're using, it is a honey that is designed to go on wounds and not to go in their stomach. So if you put eating honey onto a wound, there is a very small risk that that honey would contain spores of botulism, and that could cause gas gangrene, which isn't a very nice thing to have. So just make sure that you're using the correct honey. People come in with all sorts of things and say, will you put this on my wound? So just have a look at the packet first. There are medical grade honeys. So somebody asked me about this earlier. How do we decide whether it's a wound that we can heal with dressings, or a wound that actually, or improve with dressings, or is it a wound that actually needs antibiotics? So NERDs and stones is another acronym. Everybody loves acronyms. So if the wound is just non-healing, it's got exudate, the wound surface might be red and bleeding or very friable, so you touch it or almost you look at it and it starts bleeding. There's a lot of debris on the wound, and there's maybe a slight odour there. It might be just that it's just completely static, it's not doing anything. And you often find this with chronic wounds, that they don't show the typical symptoms that an acute wound will show. So with an acute wound, if it's heading towards the track of infection, you'll see possibly pus there, you'll see a lot of inflammation, heat, and so on. A chronic wound, it might be just that it's doing absolutely nothing at all in spite of your best care. So that might be a sign that that wound is critically colonised. It's got too many bacteria living in there for the wound to be healing. So therefore, we can look at a topical treatment, which could be what any one of them dressings that we talked about recently. However, if the wound is getting bigger, if there's satellite areas, so last week you had one wound, this week you've got lots of small wounds around that wound, or you've got bone exposed, or you can actually feel bone in there, or you've got a big increase in exudate or erythema or edema, and it is quite offensive smelling, then these are cases to consider a topical treatment as well as systemic antibiotics. So the two work in harmony together. It's also a really good tool for using to talk to people, to prescribers that may want to prescribe antibiotics when you think antibiotics aren't necessarily indicated. It's something you can use. So I'll just talk quickly about compression, because I've just put this in with dressings because it's sort of part of dressings. So we've talked about applying compression for venous leg ulcers, and the leg muscles press against that rigid tube of compression that we put onto that leg. And so therefore when the person is walking, the muscles are pressing on the veins, and the compression on the outside stops the muscle from moving outwards. It moves inwards, and it helps with the venous return. Does that make sense? Okay, so edema is reduced because less fluid can leak out of the capillaries into the surrounding tissue, and the compression helps to push the fluid from the interstitial tissues back into the vascular and the lymphatic systems and back into the body. And we can see often, once we put compression on people, that the skin changes do disappear, and that the whole leg skin will improve in condition, as well as the wound healing, of course, just because of the compression therapy. So why graduated compression? So just to explain hydrostatic pressure, if you think about when somebody is standing or sitting, the amount of pressure that it takes to get the fluid or the blood back from your foot to your heart is much more than it takes to get the blood from here back to your heart. Okay, so you need a lot more pressure at the ankle than you do at the knee because it's got further to travel. So external compression is applied in a fashion that provides higher pressure at the ankle and lower pressure at the knee. These aren't my patients. These are patients from the internet, pictures I got from the internet, but they are all typical of poor compression therapy. And generally, if you're not trained, or you may have been trained, but you haven't done it for a long time, so therefore you're no longer confident or competent, please don't do this, because we can cause far more harm than good by doing this. There are much easier ways. This is one of the ways that I recommend for patients or staff either in general practice or in residential aged care facilities, or any areas that aren't using compression bandaging on a regular basis. So this is almost fail-safe, and it also means that the patient has, which is sometimes good and sometimes bad, a little bit of control over the compression. So if somebody has a mixed venous arterial disease, this is something that they can wear the 3 layers during the day when they've got less pain, walking around, they can wear 3 layers of compression. However, if they go to bed at night and they develop pain, they can take the top 2 layers of compression off and just go to bed in the long layer. So they can manage that. It's also something that you can put on and say, if you do have any problems with it, take the top layer off. If you still have problems, take the second layer off. On the table over there, there are some of these brochures. You can also download them from the internet. It tells you, on the brochure, it will tell you the size for the circumference of the ankle. And it is very, very effective. Yeah? It varies depending on the person and previous experience. So sometimes we have patients come along and they say, I'm not having compression, I had that before, it was too painful, it didn't work, I hated it, whatever reason, they're not having compression. So rather than go to bandages, which they recognise and already dislike, we might go to this. And we might start off with 1 layer. If somebody is absolutely adamant they're not having compression, we might start off with 1 layer, and then next time they come back, or we might give them 3 layers, already cut to size for them, so wear this for a week, then after a week put the second layer on the third, and then on the 3rd week put the 3rd layer on. But it is something that they have some control over, so it does work well for a lot of people. Not everybody, of course. But of course, any bandage can cause problems. Okay, so we're going to get back into our groups now, and I want you to have a look at the intervention for your patient, so your management plan for your patient. You've looked at the history examination, investigations, diagnosis. What dressing are you going to use on this wound? And are you going to use any other interventions such as compression therapy? And we'll have 10 minutes doing this. What we might do now is, I want the groups with the same case studies to all join together, and you can compare your results, and then after you've compared, you can discuss with everybody else what you've done with your particular person. So what we'll do is get everybody that is looking at Ruby to sit down at this front table, everybody that's looking at Molly over there, everybody that's looking at Mavis in the middle, and everybody that's looking at Ted, middle right. Give you a few minutes to discuss this. If you want more butcher's paper to write out your consensus, there's more paper down here at the front.
So we had, I've got 5 minutes. We had the lovely Ruby, delightful elderly lady, rheumatoid arthritis. As you can see, we had some questions there in our history. Rheumatoid arthritis, what medications is she on? Methotrexate or a prednisone or some sort of autoimmune suppressant type thing, so that might be delaying healing. We had an ABPI, which we'll come to later. We figured her diet's probably okay because she lives with her family. She helps with meal preparations. It was a dog bite, so we don't know how long ago it was, what was the timeline, and we really want to find out how long it's been, why it's failed to heal. And we also figured that she had pretty good hygiene because she's very clean and well presented and tidy overall. Have I summed up everything? Okay, so looking at the wound, we've got a slightly sloughy wound there. Edges are rolled in. On the bigger pictures of the leg, we could see some varicose veins, some engorged blood vessels. There's a bit of dry skin too, so we're looking at some dry peri-wound area. Bit of edema. We wondered if there was that there, and we're in the middle picture you can see the outline left by the duoderm wafer that had been used. Investigation-wise, we've got an ABPI of 1.14, so that puts her into the venous area. We wanted to look at her recent blood test, check her HB, her protein and albumin. At my practice, we've also been looking at vitamin C intake because there's recent research. about vitamin C and scurvy causing delayed healing in wounds. So diagnosis-wise, we felt it's probably a venous ulcer, but we did wonder, it is a bit deep and punched out. If there's a little bit of arterial history mixed in there, please jump in if I'm forgetting anything. So implementation, moisturiser for the whole leg, not just the wound, because we've got that dry skin and we want to protect the peri-wound. Looking at debriding the slough out, so we've been tossing around different things. Because the wound's static, we were looking at something antimicrobial like some protosan or some flamanel. I guess we could even use some therapeutic honey, though some of my doctors are pretty against honey. Then we were tossing up algicite too. Sometimes we've used gel and algicite, and we're discussing the pros and cons of mixing your dressings, and compression, graduated compression. So.
Excellent, thank you. Anybody got anything else to add? No? Good, great, okay, well done. Well done, Team Ruby. Oh, actually, just going back there, sorry, you did say it was possibly venous. Just something I probably didn't make clear earlier. It probably isn't a venous leg ulcer. It's a traumatic wound initially. However, it could well be delayed in healing because of venous insufficiency. Yeah? Yeah, exactly. Yeah. Yeah, so yeah, good work. Okay, Team Molly. Do we have a spokesperson?
I'll make it 3. Hi, I'm Jay. So we had Molly, and you can see basically up there, mild intellectual disability, frequent UTIs, ABPI of 1. She's had some previous vein surgery. We don't know any more than that. Lives with her sister, argues, insists on dressing her own wounds, will not have compression, but she goes to a day centre twice a week, and previous management is up there. So in relation to Molly, obviously, what are we going to look at in relation to her history that we'll have to take into consideration in dealing with her wound and managing it. Mild intellectual disability, her ability to understand and comply, her frequent UTIs, in that she may be a bit immunosuppressed, or she may be on low-grade antibiotics all the time. Her ABPI, when was that done? We've got no data on that. We don't even know if it's current or and it couldn't be done on the leg as it is at the moment. She's overweight. What's her nutrition like? Just looking at things like, does she smoke, alcohol status? She's also had that venous surgery, and we're not quite sure what went on there. The wound edge looks a bit rolled, some erythema, wound bed is a bit fluffy and slightly red. We don't know how long she's had that wound for, and whether she's been managing that at home herself or when it was last reviewed by a healthcare professional. Just to look at things like, or also it looks like it might be a bit dry, and she's got a wound on her ankle as well, and is that a satellite wound on her ankle? And is there a bit of hypergranulation there? relation to what investigations we would do, we probably want to do her basic pathology, just some basic obs, a urinalysis, and just check her glucose, and also check to see whether she's got maybe a possible UTI going on at the moment. Maybe a venous Doppler ultrasound, her pulses, pedal pulses, compare her legs, look at her feet, her nails, a pain assessment, look at her comorbidities, and just check history in relation to has she seen any other specialists or allied health, diet, and I said mobility. She's using a stick in the picture. Likely venous ulcers. What will we do with it? Well, obviously clean it, use an antimicrobial dressing, something that's probably absorbable, and pending diagnosis, we think it's probably venous, compression bandaging. One of the big issues is that she wants to dress her own wound. She wants to self-manage. She's at home and there's a lot of, probably there's stress at home. Why does she want to self-manage? Has she had bad experiences before? Can she not get to the doctors? We need to work out what's going on there. And we thought maybe it might be something that we could work on, that she attends the daycare or twice weekly, attends a daycare centre twice weekly. Maybe we could organise community nursing to go in and dress her wounds there. I think that's about it.
Yeah, excellent. Okay. Anybody got anything to add? Always worth considering, always. Yep, yep. Yep. Just a couple of things I'll just add. She said that it could be mixed in nature. Yeah. A couple of things. If somebody presents with a wound here, most, and this is where most wounds are, where you need to do an ABPI, generally what is recommended is cover the area with Glad wrap, and that will protect your blood pressure cuff. So you can do an ABPI on this leg, providing it's not cellulitic and excruciatingly painful. Warn your patient that it will be painful and that you'll do it as quick as you possibly can. Okay, and the other thing was, we generally, if we're checking for arterial disease before we put compression on, we usually, if we can't do an ABPI, then we would recommend an arterial ultrasound, not a venous. So an arterial ultrasound, we need to make sure the arteries are good enough to put compression on. Okay, all right, excellent, well done. It could be hypergranulation. It's hard to tell from a picture. It could also be that she's been fiddling. If it's hypergranulation, there's a couple of different things you can do depending on what you've got and what your patient will allow. So one thing you can use is silver nitrate sticks. That will get rid of it. You can put pressure on it. If you've got very, very limited access to products, you can just apply pressure very tightly to that specific area, and the pressure will push it back down again, possibly. You can use Kenacomb ointment, which helps. And there are dressing products, hypertonic saline dressings, which will also, the high salt content in the dressing will dehydrate that hypergranulation tissue. But that it does need doing usually daily for a week or two. Otherwise, the dressings tend to stick. Yeah, but I'm not really allowed to say. What I suggest is Have a look at all the stalls around there. Also, you've got the ladies from Department of Veterans Affairs sitting here very kindly in our room here today. They have recently relaunched their wound management education module, and in there it's got lots of names of dressings as well as generic products that you can use. So it's free to use it, and if you talk to the ladies, they'll explain to you as well. Okay, yeah. So that was good. You went on and did other investigations. You'd been doing the right things, then you went on and did the other investigations because it wasn't doing what you wanted it to do. Good. Okay. No, not on that one. Not on that one. Remember that the first stage of wound healing is inflammation. Okay, so inflammation isn't always cellulitis or infection. So I certainly wouldn't be concerned. It's hard to tell with the larger wound, possibly. You've got to look at the big picture and has the wound actually changed at all? Are there other signs other than that redness? Are there any other signs that tell us that it might be clinically infected? And looking at that wound, it doesn't really look infected to me from these pictures. It's very difficult to assess a wound from a picture. It's far better if you've got the person in front of you. All right, let's move on to Team Mavis. You might want to come up the front. It's a really high step at this side.
I'm Sonia and I'll apologise in advance. I've got dyslexia, so if my pronunciation's up, I'm sure you know what I'm trying to say anyway. We had Mavis. Pretty much all of her medical history played a part, we felt, in the wound. Pretty much the fact's been around for 8 months. The factors we took in were she lives alone. Sorry? That better? First time I've been accused of being quiet. Okay, so with the living alone, we did query her nutrition, the hyponatremia, any dehydration. She's very much at risk with her vascular, her ability to perfuse the wound, not only with the varicose veins and the calf muscle, but also with the chest with COAD and asthma. The daily dressings, I wanted to know actually what they had before, and the factor that she interferes with them played a part. We also didn't have any access to her prior medications or the prior dressing. Okay, when we did the evaluation, we had a look at the wound bed. The tissue we decided was, you could almost loosely categorise as in thirds: epithelialisation, granulation and slough. The other team had written down pressure area irritation. We decided, just going by the picture, even though it looked like possibly a little bit moist on the sloughy area, that was largely, we categorised it as dry. So we're working on the assumption it's dry. Couldn't see any undermining or any rolling on that wound, so we assumed the edges were okay. The peri wound's actually perhaps been scratched, or when she's removed the dressing and it's a little bit irritated, it's very dry. Investigations, we would have done some bloods addressing the nutritional deficit. We want to check glucose levels just to make sure she's not an undiagnosed diabetic, the haemoglobin, also the renal function, and we had a ABPI. Perhaps, depending on how long ago that was done, we might revisit that, but it looks pretty much venous ulcer, which is what we decided to call it as, based on her history and the actual physical examination of the wound. How we were going to address it. We thought we wanted to donate moisture to this wound, so we were going to go with one of the gels. Given her fragile skin, we thought we might put on a silicone dressing and attempt to leave it intact for about a week. We wanted to go with some form of compression, given the fact that she's an older lady, my thoughts were that perhaps, given that they often did wear them as a normal stocking, that we would aim for the slightly higher one if it was a suitable product and didn't contravene anything else, with maybe the thigh-high ones. A, it's not visually looking at her when she looks at it, hides the dressing, and perhaps in her memory as an old lady, that's her normal stocking when she got dressed in the morning. So that was one thought. The other thing that was raised was perhaps to actually get her a bit more active, to try and activate that calf pump if she's physically able to, and also to engage her a bit more, so perhaps she's not as likely to pull it off because she's bored and she's seeing it if she's being more stimulated and tired. The other option, which one of the other girls brought up, which I thought was really great, was perhaps, if it's possible, stick her in for respite, get her nutrition, her hydration up to date, where she's actually supervised, get that dressing intact for a couple of weeks, and the compression happening, and then review and see what's happening. Now have a breath, and that's about it.
Well done, thank you.
I'll try not to fall off the stairs.
Anybody else got anything to add?
We literally had a lady like this a few years ago who would come in with tissues wrapped around her wound.
Yeah.
And the only thing that healed her was the introduction of heels on the heels.
Yeah.
You know,
Yeah.
once the nutrition was better,
Yeah. How simple is that? Yeah, but it worked. And that's, you know, the whole concept of looking beyond the wound and looking at the whole big picture. Well done. Good work. Anything else? No. Good. And I like the idea of putting the compression stocking on because it's the same colour as her skin. Yeah. And the other thing is there are dressings around that are skin coloured, so it's not as obvious. That might work too. But yeah, the stocking's a great idea. Okay, last but not least, Team Ted. Come on. Somebody can talk about Ted.
No, that's all right. I'll just stick it there. We had Ted, who, as you can see, is fairly complex. His past medical history is multi-layered. So in taking his history, we're bearing in mind his diabetes, his renal failure, cardiac history. But going back to basics, we want to know things about his dietary history, whether he smokes, he drinks, alcohol, his depression, how that's impacting on him. Very importantly, we want to know about his medications, what medications he's on, because he quite possibly is immunosuppressed because of his renal transplant. What pain management. We note that he has an elevated API, so we'll come back to that. His work history, interested in family and social supports, and who else is involved in his care, plus whatever allergies, and whether he has regular medical review, which we're hoping he does. With his examination, we're starting right from the beginning when he gets up to come into us, assessing his gait and looking at his footwear that he attends his appointment in. We're obviously looking at the wound, the size and appearance of the wound. Is it improving or is it deteriorating? Doing a full neurovascular assessment plus a baseline set of observations of him, because as with the diabetic, often they don't exhibit the same signs and symptoms if they've got an underlying wound infection. Just commenting on the general appearance of the wound, we felt that it was moist but not macerated. The edges were a little bit rolled and the periskin was intact, and there didn't appear to be any inflammation that we were concerned about. So for our investigations, we were going to do a screed of bloods on him. We wanted full bloods. We wanted to know what his HbA1c was, his inflammatory markers, his renal function, urine protein. Also, there was something else. Protein and albumin. We were going to refer him for a duplex scan because of that ABPI, and we were also going to get a baseline X-ray, just looking to make sure there's not an underlying osteomyelitis in correlation with his inflammatory markers. And We were going to consider referral to multidisciplinary teams, possibly not there, possibly down in interventions. So our diagnosis, which part of our history was actually how long has he had the ulcers and was there a mechanism of injury, which might have given us some tips, but our diagnosis, we're running with either a diabetic foot ulcer, a pressure ulcer, or a mixed etiology. Could it be any of the three? So our interventions, first of all, we're just going to manage the dressing. We're going to consider autolytic debridement because he has a lot of pain, so any other form of debridement would probably not be tolerated. We will obviously something on the periskin to protect that. We were considering some sort of antimicrobial dressing because of his diabetes and his immunosuppression. And our secondary dressing will be something to help with pressure offloading. We're also then going to refer him to get his pain management sorted, get him to the high-risk foot clinic for them to review him, and checking diet and depression management as well. And I think that was
well done.
where we'd got with young Ted.
Yeah, good. He was a difficult one.
Yeah.
Thank you, that was great. Anybody else to add anything? I will then. Just one thing, and I didn't mention it earlier. If you've got a diabetic and he or she has an elevated ankle brachial pressure index, if you have access to a toe pressure cuff, or if you have access to a podiatrist, because they usually have them, a toe brachial pressure can be done instead of an ankle brachial pressure. And the capillaries in the toes are far less likely to be affected by the atherosclerosis than the arteries in the ankle. So, yeah. Okay. Things that I would like you to remember from this very, very long session today are to just assess the whole person, treat the underlying causes of the wound not healing, debride by one method or another, debride any devitalised tissue, manage the bacterial load, look at moisture balance with your dressings, and reassess regularly. And if in doubt at all, just ask. There's always somebody that knows, and none of us know everything. We all have to ask at times, so please do ask and don't be frightened to ask. So that takes us to almost 1 minute of 12 o'clock. If you've got any questions, apparently we're not having lunch till 12:30, so if you've got any questions, please ask. I'll be around for half an hour or so, or if you want to dash off and whatever you want to do on your lunch break, that's fine. So thank you.